The medicalization of premenstrual symptoms into a formal psychiatric disorder known as premenstrual dysphoric disorder, PMDD, is a vivid illustration of how the boundary between genuine medical care and strategic pharmaceutical marketing can become dangerously blurred. While PMDD is very real for a small subset of women who experience severe, debilitating mood changes tied to their menstrual cycles, the way it was introduced, framed, and marketed, especially during the rollout of Sarafem, a rebranded version of Prozac, suggests a calculated expansion of psychiatric diagnosis to open new profit channels for an aging drug. The consequences were not overtly harmful in the catastrophic sense, but they represent a quieter and more insidious shift in how emotional experiences, especially women's emotional experiences, can be pathologized and monetized. In the late 1990s, Eli Lilly's patent on fluoxetine, the active ingredient in the blockbuster antidepressant Prozac, was set to expire. Facing an imminent loss of exclusive profit rights, the company sought to extend the life cycle of its billion-dollar drug. One of the strategies it pursued was to rebrand fluoxetine under a new name, Sarafem, and secure approval to market it for a newly recognized condition, PMDD. This version of premenstrual syndrome, PMS, was framed as a distinct psychiatric disorder marked by extreme mood swings, irritability, depression, and anxiety occurring in the luteal phase of the menstrual cycle. The FDA approved Sarafem in 2000, and almost overnight, the pharmaceutical industry had turned a natural, cyclical physiological experience into a mental health diagnosis requiring pharmacological intervention. What followed was an aggressive marketing campaign that reframed normal hormonal variation as pathological. Ads featured women struggling with relationships, anger, or sadness before their period, with the suggestion that these feelings were not just bothersome, but abnormal. The messaging was subtle but clear. If you feel emotionally different before your period, you might have a psychiatric condition. And if you do, there's a pill for that. The fact that Sarafem was chemically identical to generic fluoxetine was downplayed or ignored. Its pink-colored pills and gender-targeted branding gave the impression of a novel, specially tailored treatment for a condition that only recently had been formalized. The creation of this niche market was not based on new pharmacology, nor did it reflect a breakthrough in understanding women's mental health. It was a business decision disguised as therapeutic progress. PMDD as a diagnostic category had been debated for years within the psychiatric community, with significant disagreement about whether it represented a distinct clinical entity or a spectrum of emotional responses to hormonal shifts. Many critics argued that while some women do suffer from severe premenstrual symptoms that warrant attention, the path to treatment should not begin with medicalizing those symptoms as a mental illness, especially when the threshold for diagnosis is so subjective. Yet, once PMDD was recognized in the DSM, first provisionally in DSM-4 and then more formally in DSM-5, the pharmaceutical industry had the green light to promote medical intervention for what might often be situational, hormonal, or social in origin. The implications of this framing are complex and problematic. On one hand, acknowledging PMDD as a disorder helped validate the suffering of women who had been dismissed or told to tough it out. But on the other hand, the condition's formalization was largely driven by drug marketing, not grassroots patient advocacy or a paradigm shift in scientific understanding. By shaping the public's awareness through commercial campaigns, Eli Lilly and others essentially created a demand for their drug in a new therapeutic category, one that could be expanded to include millions of women experiencing ordinary emotional fluctuations. There are also ethical concerns about reinforcing stereotypes of female emotional instability. The notion that women are periodically irrational or mentally ill due to hormonal changes has a long, misogynistic history in medicine. By codifying PMDD as a psychiatric disorder and aggressively marketing pharmacological treatment for it, pharmaceutical companies risked legitimizing these stereotypes under the guise of medical science. It also invited overdiagnosis. Many women with moderate PMS symptoms, irritability, fatigue, moodiness, may have been told they had PMDD and were offered antidepressants as a first-line treatment, despite the absence of strong evidence supporting such an approach for milder cases. Furthermore, the use of SSRIs like fluoxetine for PMDD introduces a broader concern about pharmaceutical overreach into non-chronic, time-limited states. PMDD symptoms, by definition, recur monthly and are confined to a short window within the menstrual cycle. Treating these transient episodes with daily or even intermittent antidepressant use may introduce side effects, dependency concerns, and unnecessary exposure to medication risks, including emotional blunting, sexual dysfunction, or withdrawal symptoms, without addressing underlying hormonal or psychosocial contributors. What makes the Seraphim story particularly telling is how it reveals the pharmaceutical industry's ability to reinvent old products through rebranding and reframing rather than innovation. Fluoxetine was not a new molecule in 2000. It was simply repackaged, renamed, and repositioned for a market that had not previously existed. The strategy worked. Seraphim became a commercial success, and the practice of diagnosing PMDD expanded throughout the 2000s, even as controversy around its validity and scope persisted. In retrospect, the medicalization of PMDD illustrates a deeper dynamic in modern healthcare: the commercialization of diagnosis itself. When disease categories are shaped not only by clinical need but by market opportunity, patients can become customers before they become beneficiaries of real care. Emotional nuance gets flattened into diagnostic labels, and normal variations in human experience, especially in women, are increasingly viewed through a pharmaceutical lens. The story of Seraphim is not simply about antidepressants. It is about how companies identify and exploit gray zones in medicine, where suffering is real but the boundary between treatment and marketing becomes disturbingly porous.